Hello and welcome. This is 8 p.m. UK time, therefore it is time to start our IVF webinar. It's good to be back. My name is Caroline and I am your host as always. And of course, again, we do have another very important, very interesting topic. And there are also two very special guests from another clinic. And of course, before that, just let me remind you that we are here every single day to support you throughout your IVF journey, but also we definitely want to make sure that you will be able to ask your questions to top fertility experts. So as you know, we've been supporting you from the very 1st of April, and we will continue to do that until the end of June. But of course, we will be back very soon with more live events as well. But also, let me just remind everyone that all the Stronger Together events have been brought to you thanks to our ambassadors and partners. So, of course, as always, I want to thank them for their support. And well, today, as I mentioned, very interesting, very important topic that we have, which is failed IVF with own eggs, causes, and what you can differently on the next attempt. And I'm sure many of you have been already asking this question. And today we do have two experts that will be able to help you with this question as well. And it is Dr. Bogna Sobkiewicz, gynecologist, and Dr. Małgorzata Wójt, the head of embryological laboratory and senior clinical embryologist at Salve Medica in Poland, both Warsaw and Łódź, of course. Both clinics are located in Poland. And of course, Dr. Bogna and Małgorzata, they will start with their presentation. But after that, it will be time for your questions. So as always, all you need to do is just type in all the questions in the chat section so they can help you out, of course, with all the questions. And well, just let me know that you can hear me loud and clear, okay? So we can make sure all is working. And well, Dr. Bogna, Małgorzata, how are you? First of all, how are you feeling today?
Thank you. Fine. Good evening.
Good evening.
Good evening. It's good to have you with us. I am really, really happy that you've decided to come back because both of you have already a webinar with us. I'm really happy that you have decided to join us once more and present this topic. And well, are you ready to start with the presentation?
Yes.
Excellent.
Yes, we are.
Go ahead.
Today we will talk about failed IVF with own eggs, causes, and what you can do differently on the next attempt. In order to understand why in vitro procedures fail, you have to get to know the following: gametes, embryos, transfer, uterus, immunology. These are the main factors that are involved in the whole process. Sometimes only one of these factors has an impact, but sometimes, unfortunately, there are several that overlap. Causes of failure to conceive with own gametes. On the part of women, we have a list of the following. This is quality of eggs and number of eggs. Quality of eggs depend on woman's age, MAG, endometriosis, but number of eggs depends on age, also MAG, and state after ovary surgery, sometimes after oncological treatment. Of course, some of these factors don't depend on our will, and we cannot change them. For example, age or MAG. But we also have factors that have a big impact on the quality and sometimes also always the number of oocytes, but which are modifiable. And depends on our lifestyle. For example, smoking and obesity.
Other causes are because of the state of the uterus, like polyps, myomas, uterine abnormalities such as septum or bicornerate uterus and adhesions. That means the Asherman syndrome. Also, the state of endometrium is very important for us, like uterine submucous myomas, quality of endometrium after uterine curettage, that means the adhesions, inflammatory conditions of the endometrium, number of natural killer cells in endometrium, and endometrial receptivity. You have, this is now it's a very popular topic, the state of the endometrium in reproductive medicine. We try the whole family of the reproductive medicine, look for the causes and look for the best new treatment, the new tests to find out where is the problem. It takes some time to find a new solution, but you have to know that the whole Europe, the whole world are looking for the solution and to find the problem. And the transfer quality, it is very important because for us it's very important because when we perform the transfer, it's something what we can see and what we can change, and sometimes it is very stressful for us when we perform the transfer and we see that there are some problems. You have to know that we use the catheter. They are very, very delicate. They're a little bit more stiff than the gel. So we try to perform it as easy as it possible and without any disturbation. So the presence of the scar after cesarean section, when the catheter is stopped by the uneven surface, is very stressful for us. The anteflexion and retroflexion of the uterus, it's may cause some disturbance for us. We try to use to prepare our patient as much as we can, but when they have the retroflexion of the uterus and after the cesarean section, it makes very difficult and even sometimes impossible to make the transfer on the normal way through the cervix. Sometimes it needs to do in another way, but it's always not as smooth as through the cervix. We, as I said, that we try to prepare our patient before the transfer. We do the scratching in proceeding cycle, and it allows us to know if we can go through the cervix, through the intern of the cervix, and sometimes if we cannot perform it, we know that we have to help our patient to make the lumen of the cervix a little bit wider. Transfer quality resulting from ultrasound imaging quality. We always do the transfer under the ultrasound imaging. We never do it without it, because we believe that it is very important not to touch the fundus of the of the uterus with the catheter, and for us it's very important that the quality of the image is as good as we can as we can as we can show, and sometimes it is for us difficult because of the obesity or unfilled urinary bladder. That's why we always emphasize our patient that they drink before the transfer. We ask them, and we always try them to have enough time to drink.
The next factor is quantity and quality of semen. Lack of performance of additional semen tests that could point to other semen deficiencies, some of which could be counteracted with the use of adequate in vitro technologies. We also can't forget that sometimes a couple's problems overlap, and if you have even small problems with semen quality, with sperm quality, and also small problem with quality of sites, together this pair doesn't have two small problem, but generally have one big problem. Of course, all sites have high self-healing abilities and can fix some errors in the early stages of the embryos, but not all. First, we don't remember. There is no good embryo from weak oocytes, but it can be possible a good embryo from weak semen. As you can see, sometimes natural biology is not always fair. The next problem is connection with failure is genetic abnormalities. In some situations, we have genetic loads on the one of the partners, such as incorrect karyotype, translocation, and other. But this is not a very common situation. Unfortunately, a very long proportion of our as a human embryo are genetically abnormal. Most of these errors arise during the cell division of the gametes and embryos and are completely accidental. The number of errors increases with the age of women, hence the efficiencies of IVF programs decreases. We also have a lot of monogenic diseases, but the effect is less, and this is a topic another presentation.
When we cannot find in previous topics and cause of the field of the IVF, we go to the immunology. It is a field that is still in progress, but we look for the main problem, like we perform the MAR and the test of MAR, and the high MAR are the MAR values are high. And we look for the immunological problem in women, such as lack of inhibiting antibodies, like low values of MLR tests, or abnormal relations in antibody natural killer cells, lymphocyte T, CD4, CD8, or TNF. When we have the disorders in these values, we know that the body of the woman can produce the antibodies or any other cells or cytokine that will not allow the pregnancy to come to grow. you have to know that we never start to look for the causes before we know that there is the problem. So sometimes we perform 2 or 3 IVF or the transfer, and then we are looking for the cause. The tests are usually stressful, and they are not cheap, or they need some time to be performed. But so we are always starting with the tests that they are the simplest, the most easy to and accessible, the cheapest, or the less invasive. In our clinic, we usually start with, or rather avoid, those causes even before we proceed to the in vitro procedure. So, as Gosia said, that the quality of semen is not the most important, but it's still important. So we perform the easy test like SWIMAP, HbA, the FI, MAR, or the semen culture and PCR test regarding infectious agents. These tests are very easy to perform. We do it from the semen probe, and we can find and we can try to use the adequate techniques to increase the success rate. And we have some
tests,
some tests, and we can use another possibility
to semen preparing to during procedure
to receive the most success
in a better embryo. Sometimes
due to the choose of the best sperm. We do the ultrasound to find the problem of the uterus. We do the ultrasound scan. We perform it quite regularly, the ultrasound scan, but when we have a problem, sometimes we look for even for the small disturbance. So we perform ultrasound 3D ultrasound scan to look for the smallest thing. After some of the IVF failure, we do the hysteroscopy to look into the uterus and the cavity of the uterus, and to look for the polyps, like we said, myoma, adhesions, or any other problems, or the septum, or the bicornuation. We do the uterine cavity cultures to look for the infections, and we perform endometrium tests looking for natural killer cells and the level of in the endometrium. And we also can perform MRI, but it's very rare, and it's because it's more expensive and more you have to have really indication for this. Through analysis of conducted transfer, the evaluation of experience of specialists conducting embryo transfer, we check our successful rate. We have the supervising. We do the presence of blood outside and inside catheter. We also, it's for us, it's very important to know if there was any any bleeding. There are some type of bleeding. One are not as important, and another are much more important. And then you can just during the transfer they can ask, they inform us if the transfer will be successful or not, or it is less probably that it will be successful. There are registered in embryological records for each embryo transfer, on evaluation of transfer done by the person conducting the transfer. Because when we perform the transfer, for us it is always easy to check our own experience, our own how to say, possibility to conduct it, and so it is easier for us to check if we are okay or not. In case of less experienced team members or members with decreased effectiveness, the most experienced doctor supervises conducted transfer in order to eliminate possible error, as I said before. Performance of scratching in proceeding cycle. As I have said that we routinely perform scratching in proceeding cycles. Some of my patients ask me if it is obligate, why we do it. There were some articles in UK that they said that the scratching is meaningless, that we shouldn't do it, and that maybe it is too much. But we perform it on. It's very easy to do. It's easy to prepare our patients for these procedures, but the effect is much bigger than preparation, because we know that due to the scratching, we know that the catheter go smooth through the cervix to the cavity of uterus, and what's more, but it's additional, we do the scratching, so we scratch the cavity and the endometrium, and those they in the next cycle they produce another cytokine, another small products that make the transfer a little bit more success. And every step, every few percent that make this more success for us is very important, because when you count here, you can have 5% more probably that it will be successful. Then you can find in another procedure 5%, and then it's together it makes a bigger difference. When we know that the quality of the embryos is high and everything is okay, the transfer was conducted without any problem, there is no problem of the uterus, we perform the detailed immunological tests like CBA, AMK, ML here, but in women and LH in a man. Those are more, I'm not the immunologist, so I'm not very good at this, but we always cooperate with our immunologists that they perform this test just to look for another reason and to adjust the treatment for them, because even it is important that to use the good treatment, because sometimes when you don't do this, you can use the treatment that can harm. In patients with abnormal results of the aforementioned tests, we perform the following procedures in cooperation with immunologists, such as immunization with partner lymphocytes that decrease the percentage of embryo rejected by the woman's organism. We include immunological treatment, and we administer intralipid or any other. In patients suspected of excessive uterine activity, we administer drugs that decrease uterine contractions during embryo transfer. Sometimes when we perform the ultrasound scan, we can see the contractions of the uterus, and it's not still sure, but as I said, we try to find as much causes as we can and to use as much as we can. In our patients that are after a lot of IVF failure, we do the endometrial receptivity assay. We conduct embryo transfer in accordance with the designed ERA test. It is performed in we do the test here, but the laboratory is localized in Spain, and we sent there the samples, and then they said us about the receptivity of the endometrium, and those we can adjust the time of the transfer. When MH values are low, or semen parameters, stimulation results, or embryo culture results are unsatisfactory, we consider discussing with the couple the validity of the following procedures: adoption of donor egg cell using donor semen, and adoption of embryo. We always try to find the best solution for this couple, and to because when we see that sometimes the quality of the egg gametes is okay in if the woman of the female gametes is okay, so we try to use the donor semen. If it's in another way, we try to find just the best solution. The adoption of embryo is always the last our last to choose. As I said, that our dedicated and tailored approach to treatment help us to achieve one of the highest success rate in Poland. We have there's some mistake. We have more than 17 years of experience in IVF. We also passionate team of doctors, medical, and supporting staff.
Our results.
Fresh donor eggs cycle with it is 58%. With frozen donor eggs is 56, and
average number of embryos transferred per embryo transfer is 1.1. Generally, we transfer only one embryo. And preferred embryo transfer, there is blastocyst stage. For example, in donor cycles is always 5 days embryo transfer.
Because we vitrified.
Because we vitrified blastocysts, so it's always
the best also success rate. So we do not try to. We just try to find the best thing we can.
Thank you.
And excellent. Thank you so much for bringing this topic to us, and of course for your presentation, providing us all the details. And well, now as always, it will be time for our Q&A session. So of course, I just want to remind everyone, if you have any questions, this is your time to ask them, so that both Małgorzata and Dr. Bogna can help you out. So don't miss that opportunity. And of course, there are some questions ready. So are you ready for them?
We are.
Yeah.
Okay, excellent. Good to hear this. So let's start with the very first question right here. So, what is the average number of IVF with own eggs attempts before success?
It is a very difficult question because it's depend. Of course, the younger women have completely different success rate. Than older patients.
It's like in Poland we have. It's also one of this is that it is. We look at the age of the couple. We look at the quality of the embryos. We look at different things, but we also look like that. We know that in Poland there are only three attempts with treatment that are refound by our country. So it's also very important because so there are so many different and also we look at the will of the couple. If they want to try more and more, we always they inform that sometimes it is meaningless, or the successful rate is very low. But if the couple would like to try always with as much as possible with their own gametes, we also do it, but we also always try to tell them that it is the successful rate is low.
All right, excellent. Again, thank you so much for this question as well as your answer to that. All right, next question is a bit longer one. Okay, so let's have a look at it right now.
Oh, we cannot see.
We can
I will read it and then, of course, change. So you should be able to see the whole part. Okay, I hope. Okay, let's start. So before my next IVF attempt, one failure, I did hysteroscopy, and the conclusion of the biopsy was that signs suggesting chronic type endometriosis and some evidence that could support the presence of a benign hyperplastic lesion, such as endometrial polyp or endometrial hyperplasia. What we concluded with my doctor was to proceed with egg retrieval and fertilization with sperm donor due to low AMH 1.07 nanograms and my age 38. Do the appropriate treatment, antibiotic injections into the endometrium and antibiotic pills, and then do hysteroscopy again before proceeding to embryo transfer. Do you agree with this approach?
Yes, of course. However, you have to know if there is some, as you said, endometriosis type of it always may cause some problems, and it's a little bit more difficult to treat the endometriosis, especially the adenomyosis. So you have to just know that the can be a little bit more problematic for you. But I agree that it's important to start with the egg retrieval and then to cope with the endometrium problem.
All right, excellent. Thank you so much for your question and, of course, for your advice, your recommendation to this question as well. And there's another question from the very same patient. Okay, so let's get to this right now. And here it is. After scratching, when you should proceed to embryo transfer? For example, if you do scratching and proceed with embryo transfer 6 months after, well, scratching has the same effect as if the transfer was performed 1 month later?
No, we do always in the previous cycle. We know after the 6 months, it can when we what we know that the scratch after the scratching, the cytokines that are produced in the next cycle are changing anything. Okay, after the 6 month, we know that the catheter should go also smooth, but it will not be this production of the cytokines and other small.
Okay, again, thank you so much for your next question, and of course for your explanation to this one. And of course, there is another question right here. So let me show you that. I am 45 and have NK cells. I've had 2 failed attempts, IVF and ICSI, and am now considering egg donation. Would you recommend doing this, and would the NK cells prevent it from working? Do you have to have extra treatment for the NK cells before proceeding? Is there anything I can do or take to help suppress these cells?
We are not the immunologist, so I'm not a good person to answer these questions. And it also a little bit difference between the natural killer cells in the endometrium or in the blood in the. So it also depends about which natural killer cells we talk, and we all have natural killer cells. And for example, in the endometrium, it is important of is it high or is it low, but it's a little bit too less. It's not enough information for us, and as I said at the beginning, we are not the immunologists, so we are not.
Of course. Thank you so much. And well, I can advise, of course, I will send you the link where you can, of course, ask your question if you wish to get some more details. Yes, because as you mentioned, Dr. Bogna, you would need definitely more details from the patient. So I just want to remind everyone that if you would like to get a thorough consultation, I guess, as well, you can also use this link, and there is an option to ask your questions, and of course it will be forwarded to either Dr. Bogna and of course Małgorzata, and I'm sure they will be able to assist even more, right? Okay, thank you so much for this. And now let's have a look at the next question. There are 2 parts of it. Do uterine contractions have a major impact on the success of a transfer? My previous transfer have been quite painful, as I have a titled cervix and they struggle to get this catheter in. What would you suggest to help with transfer? And follow up, I should also add that my clinic does not believe in doing a uterine scratch. And let me go back to the first.
That's as I said, for us the scratching has the solve 2 problems. One of is the scratch, and another is that it allows us to go through the cervix, and sometimes we do the hysteroscope when we have the problem to do the scratching, to put the catheter, the special catheter to the uterus, and we know that we have problem. We perform like hysteroscopy to find how the way is. Where does it go? Because sometimes it's going more to the left, sometimes it goes to the more to the right, and when we do the hysteroscopy, we can find how it goes, and it allows us then to go with the catheter with this way. And the contractions. When we perform usually the transfer, we try to not to touch the fundus, not to do as smooth as we can. We use the very delicate catheter because we do not want to have the contractions. We do not want to have any pain. We do not want to do any pain to our patients because we believe that it can diminish the probability of success.
All right. Thank you so much once again for your question.
I just can tell. Sorry, I just can tell that we always try to find, but even we sometimes have to struggle, and sometimes we also have the problem with to do the transfer, and we always try to do it as smooth. But this is medicine. Sometimes it's difficult to know something before, and I would like to know always to what to do before, but sometimes it's impossible.
Of course, again, still thank you so much for this, and I just want you to okay, so I'm just waiting for some more questions. So if you have any left, go ahead and type those in so that we can help you out a bit as well. And well, we will be slowly finishing, but of course, I just definitely want to make sure that you have asked all the questions indeed as well. So let's have a minute. Let's see if there are more questions. If not, we will be finishing. But someone, of course, is typing. So let's make sure and let's have a look at it. We just need to wait a second. All right, someone is still typing. So again, we just need to make sure that we do have another one. So okay, yes, there is another question right here. So let me go to that. Hello, have had fibro done in laparoscopy, already failed 5 IVFs. What is the best way to go?
It is fibers. It is difficult to say because we have so many different types of fiber of the myoma, and it depends on where they were localized. If they touch or go to the uterus cavity, because if the myomas fibroids were out of the uterus, they are less important for us unless they are not very big. But if it is also important if during the laparoscopy of the if the cavity was of the uterus was open or not, if there are any scars on the uterus. There are so many different problems that it is important to know. And even though that, as we said, sometimes we know that there are fibroids or the myomas, but there's another problem as well, like low quality of semen of of the eggs of the gametes or the embryo. So even if we know that there is a problem with myoma, it can be still another problem that is just difficult to diagnose.
Yes, of course. Still, thank you so much for this. And again, let me just remind you that if you would like to get some more details, it is possible. Just, I'm sure Dr. Bogna will just need some more from you. So you can use the link I have just sent to you. And there is another question. So let me show you this. So I have low AMH. Is there any supplements you recommend to help improve equality?
The egg quality, it is, it is difficult. Sometimes we know that now sometimes when there is a low MH, we know that the DHEA, when you use it like 2 to 3 months before the egg retrieval, it can be a little bit. It can a little bit can help a little bit. So there are some studies that growth hormone can be a good solution, but it's there is no it is very it is difficult to use. It is very expensive. There is no refund in Europe for the hormone for the growth hormone, and it's a little bit still experimental to use it. Sometimes it is good to use the transdermal testosterone, but even though sometimes when we try to help our patient and we use these solutions, even though sometimes it when the egg quality is low because of the age or low MH, it is difficult to help.
Also, it depends also with age of patients, because sometimes low MH in a younger patient is better than older patients.
Yes, the genetic is like that. We are aging and with and our gametes as well.
No, of course. Again, thank you so much for your question, indeed, as well as your assistance with that. Patient has added that she is 35. Yeah, so of course,
It's
this
not
is
just.
just
Mhm.
additional one.
Mhm.
All right, thank you so much. I'm gonna do not see any questions, so we will be slowly finishing. Oh, sorry, there is one more. Just popped out just here. So I believe it will be our last question for today. So let's have a look, okay, at this one. It's regarding the DHEA. So does it only help with equality due to low egg reserve, or can you also take it if you have a higher than average AMH? I've heard it helps with recurrent miscarriages as well.
I haven't heard that it helps you with recurrent miscarriages. So I don't know if if there is any sense to take it with the higher average MH. We try not to ask our patient to take everything what they can, and to because sometimes it's the patients they look for the solution, so they can they do some things that that they have no studies for this. They have no good how to say that they're like experimental therapy. So we do not we do not recommend this.
Of course, thank you so much for the clarification to this as well. And well, the patient has added, yes, that it's from the book that she has read. It starts with the egg, but of course, as you mentioned, well, it's I guess it's not really recommended. But thank you so much for sharing this. Yeah. Excellent. And I believe that was our last question. But of course, let me just remind everyone that if you have any left, you can also use the link I have just sent to you, and that way you will be in touch with the with Dr. Bogna as well as Małgorzata, and I'm sure they will be able to help you. But of course, anyone from the clinic, I'm sure they will be happy to get back to you and provide you with more details. And also, let me remind everyone that this has been recorded, of course, so you will have a chance to watch this. It will be available on our website tomorrow as well, My IVF Answers. And thank you all for joining us today for all of your questions. And of course, Dr. Bogna, Małgorzata, thank you so much again for joining us
Thank you.
today, for your expertise, and of course for that presentation on this topic that I know we could probably spend a few hours with because there will be so many questions in regards to this particular topic. So thank you as well. As you can see, there are patients here that would like to thank you as well. So
Thank
thank you
you.
so much. And once more, let me remind you that we will be back here tomorrow at 8 p.m. UK time and at 6 p.m. UK time. So I hope you will be able to also join us tomorrow. And also, I can only say once more, thank you so much to you, and have a lovely, relaxing evening, everyone. And Małgorzata, Dr. Bogna, it has been a pleasure. Thank you as well, and have a
For us
lovely
as
evening.
well.
Well,
Thank
thank
you.
you.
Goodbye.
Goodbye.
Bye.